Hello, everyone, and welcome to the Collaborative Family Healthcare Association's monthly webinar series. My name is Polly Kurtz, and I'm Executive Director of CFHA. We're pleased to have you all with us today. Our webinar for March is Moving What We Know About Integration, the Integrating Behavioral Health and Primary Care Trial. Our speaker today is Dr. Roger Kessler. Dr. Kessler is a health psychologist practicing in family medicine for over 20 years. He's Associate Professor in the Department of Family Medicine at the University of Vermont and Associate Chair for Research and Evaluation in the Doctor of Behavioral Health Program at Arizona State University. He is the co-principal investigator on the IBH-PC Comparative Effectiveness Trial, supported through PCORI, and to evaluate the outcomes of co-located and integrated models of behavioral health care as part of primary care. Dr. Kessler has an extensive resume and bio, and if you're interested in learning more about him, you can find his full bio on the CFHA website. I'd like to pass the presentation to Dr. Kessler at this point, and we'll go ahead and get started.
Good afternoon, everybody, and thank you so much for taking your time to join the webinar. I want to quickly introduce my colleague, John Van Luling, who's on the webinar with us, who is my go-to for all things technical and is primarily responsible for putting this presentation together, the visuals on the presentation. So as many of you when we talk about integration and have been arguing for it without a great deal of data to support it. And frankly, I kept hoping that somebody would get it together to move that forward and put a large trial together to evaluate integration. And as that hadn't happened, we wound up doing it ourselves and developing the Integrating Behavioral Health and Primary Care program that's been funded by PCORI at the University of Vermont. My colleague Ben Littenberg, who is an internist and trial researcher, and I are co-PIs on this application, and my colleague Connie Van Eegen is the kind of project director as well as being a co-investigator. So I'm told this takes a few seconds. And let's see, what am I going to do? I'm having a hard time seeing the left part of the screen because the presentation stuff is in the way. Let's see if can I move it? Oh, I can. Lovely. So the first thing that I think to underscore is for me and for us, this has to be primarily a medical trial. And as you can see, the majority of the investigators are primary care physicians from around the country, both heavily involved in primary care integration in the case of Roger Cathal and Sarah Scholey, for example, and to some degree Kurt Stengy, and other folks who are involved in other aspects of primary care research, such as Chet Fox from Buffalo and Wilson Pace from Dartnet, who is responsible for all data extraction. So why is it doing that to me? Uh-oh. Let me see what I can do. Yeah, this will work. Okay, thank you. Sorry for that. Technical glitches. As consultants on the project, we have two wonderful colleagues, Dan Mullen from UMass and C.R. Mackey from Arizona State, who are responsible for primarily putting together the training components and the modules that we will see later. Deb Cohen from OHSU will help out in terms of consulting on the mixed methods issues, and Frank Degree will be focused on developing the advisory board that we have generated, the members of whom are above. Part of what it was very important that we be able to have a broad range of view and impact and input from a wide range of situations and organizations so that we would be able to have a diversity of thought on the project as well as generate ample dissemination opportunities. So we can see that American Psychiatric, patient advocacy, CFHA itself, the Institute for Healthcare Improvement, American Psychological, the Green Mountain Care Board in Vermont, which is the organization that just primarily organizes new healthcare reform in Vermont, as well as some integration colleagues such as our friends at Cherokee and Andrea Auxier, who will add their perspectives. The way that we operate is this is a trial that will include 40 practices from around the country. And each cluster of practices have a site investigator at the point of them. And these are the folks who are involved in that role. Many of them are from the practice-based research world, and others such as Ron O'Donnell, Bill Sieber, and Dan Mullen are from our integration world. So there's been a real variety, as everybody on the call is aware, of issues and ideas about what integration might look like. And we did a study with our colleagues at NCQA a number of years ago that showed about 40% of NCQA practices who responded had some degree of behavioral health clinician. As work by others has demonstrated, when you go look at integrated practices, you wind up finding considerable variation, and much of it is closer to co-location than integration. So we were interested in the question of how are there differences between essentially taking somebody and putting them in the practice to provide services and truly integrating a behavioral clinician into the flow of practice. The other thing that I think will get clearer as we talk is that our patient focus are complex patients who have multiple medical and behavioral comorbidities as contrasted with solely those patients who were being treated for mental health and substance use disorders. The aims are to compare the two models and see which has better outcomes. The second is using a lean-based structured improvement process. Does that add to the differences between integrated behavioral health and co-location? And the third is the mixed methods question of context. What about type of practice, healthcare system, and other contextual issues? How do they influence those outcomes? As I mentioned, we have 40 sites rather, that are participating. We have had 3 recently disenroll, so it's probably down to 37, and we'll need to fill those up. But here are the states that are represented in the trial so far. basic model that we are using to conceptualize integration is to look at where leadership has determined and supported integrated care to go on within the organization. What is the structure of what integration is going to look like? What are the necessary skills? What kind of process needs to be used to impact on care, and using what tactics to enhance identification, assessment, treatment, and surveillance of patients with multiple morbidity as an interaction between medical and behavioral services. The outcomes, as you'll see, hopefully will be things that matter to patients and families. What are we going to do? We're going to provide team-based training for everybody in the practice. And we're going to have that training related to using a structured improvement process, using a toolkit that Dr. Van Egan and I developed as part of an NIH-funded project to evaluate the impact of using the toolkit on outcomes in primary care integration. As I mentioned, the training program has been developed by Dan Mullen, C.R. Mackey, and Connie Van Egan. It's an entirely asynchronous training program. It lasts up to 1/2 hour. Each module lasts up to 1/2 hour. And the training is integrated with the intervention and the toolkit strategies. So the product, while it has those three distinct elements, is interdependent on each other. What we are generating is exposure to the material and skill development. While we realize that competence is a critical dimension, we also realize that that is something that has to be learned over time in practice rather than being the product of the kind of training that we're able to generate. So we are in the process of generating 70 modules. And I'm not going to go through every one. If those of you are interested and want to get hold of the slides, happy to share that. But I'm just going to talk about the domains in which we're training. The entire team will be trained in interprofessional team-based care. We will then have modules for physicians, nurse practitioners, and PAs, as well as for care managers and RNs, LPNs, and medical assistants. Behavioral health clinicians get a very significant amount of evidence-supported training. Office staff and practice managers. A core component of our work is a facilitated lean-based process improvement activity. Dr. Van Egan and my research has demonstrated that using such an approach in multiple primary care practices has generated significant and stable changes in process as well as changes in outcomes. So there will be an identified practice facilitator in each of the 40 practices. And this will be the structured training that they will receive.
Dr. Kessler, We do have one question. Is this a good time, or would you like me to hold that for a bit?
Lovely time. It's a lovely time.
Perfect. So our question is, how do you define healthcare providers? On those lines, what is the role of social and educational services entities in the continuum of integrated care? The integration model seems to limit the integration within healthcare settings. Hence my question about a true continuum of care, linking healthcare settings with social and educational support systems that can really work on primary prevention and also prevention of chronic problems as they are linked with the social determinants of health.
What a wonderful question and comment. So, given the scope of this project, and it's a pretty large, broad-focused project, I am absolutely clear that it is extremely limited in scope. And I would say that the breadth of what we are able to do, primarily but not solely relying on what happened in the medical office, is a function of needing to be able to determine what happens in the medical office and how do you organize care in the medical office such that issues related to social determinants of health, including community-based care and issues, can proceed in a systematic fashion. My experience, and it may be different than a lot of others, is we try, reach out to respond to such issues as were just brought up. But because of the lack of organization, modeling, and resources within our office, I think we do a pretty poor job of it. And your point is well taken, and I will say again, also beyond the scope of what we're doing with this trial, unfortunately. So what Connie Van Egan and I did was develop this toolkit. And the toolkit essentially allows an organization to self-determine how they want their integration to look like. And we discovered something interesting. What we'll see here is that there are three areas of the toolkit: initial planning, generating a project team and coming up with an implementation intervention strategy, and then in fact conducting the intervention. What we determined is that essentially a lot of places, they are absolutely willing to skip over this first piece. Higher level, 30,000 foot executive and managerial planning, and jump right into, let's go out and hire somebody. And we would conclude from our work that the probability of having as effective an outcome as one would like is mediated by the degree that they participate in the toolkit. So as you can see, we've tried to identify key elements of practice functioning. Our world is very influenced by CJ's conceptualization of a three worlds model of care. So clinical, operational, financial dimensions of care. And when we look at practice activity, we look at how those domains get operationalized into activities that are part of the planning for integration. After the myriad issues in stage one are responded to, however the practice responds, we move to stage two, which is the design. And I'm getting a message that my battery is running down, so I'm just going to take about a few seconds and just go grab my battery and plug it in. Sorry about that.
As a reminder, while Dr. Kessler is getting plugged in, we will have a recording of this webinar on the CFHA website within a few days after the presentation today. We'll also have the slide deck or Prezi deck available for our participants. We'll in all likelihood send that out via email for those of you who are interested. So both of those things will be available. And just one more reminder, if you do have questions, feel free to type them into the question box in the navigation bar, or raise your hand, which is a little green button by your name, and I'll unmute you and you're free to verbally ask your question or make a comment.
Great. Thank you. So once one the conceptual structure and permissions in place, and I say that because as a small example, we were involved in a project in which a system assigned practices to integrate, and they immediately jumped in and set a start date and developed contracts with external folks and to provide the services. And then maybe a month before startup, they started talking about operational issues such as regular space, how communication was going to happen, access to the EHR, phone information, and said, okay, we'll just make them part of our system. And the next week, the feedback was the project stopped in its tracks because as they went through the permission generating levels within the organization, they were either told, no, we don't want to do that, or they were told that the system would not be easily incorporated to respond to those issues. So again, I reiterate, stage 2 is a product of the decisions that are made in stage 1. And stage 2, you guys have all seen. One puts together a quality improvement team with a task and mission. The team is representative of the broad range of players in the practice. Workflow analysis, selected strategies to move forward to respond to the barriers and take advantage of the opportunities that are seen, structured design and implementation plan, and completion of the plan, back to practice leadership for validation, and then stage 3 is the PDSA plan, implementing that which was generated as stage 2. So the toolkit has a 20-plus specific strategies and methods for incorporating the strategies that a practice may select from as it develops its integration process. And we can see the first 8 there. The next group. And the last. So a practice, as part of their stage 2 work, will work with the toolkit, identify those things that are of importance to them as they generate their integration model, and then do so in the next phase. In the trial, we are advocating that practices focus on screening. And for me, screening does not mean PHQ, GAD, audit kind of screening. It means a larger behavioral risk screen of all patients. behavioral health visits, collaboration, methods for communication, including standardization of communication, bidirectional EHR communication, a clear role of collaborating with other providers in the community for specialty mental health or other community resources. So this is our effort to respond to that well-stated question earlier, and it's limited. And then attending to optimizing behavioral health services inside the practice. One of the questions that we're interested in is, to what degree is the degree of integration within a practice influence these outcomes? Part of what we've observed in pushing on up to 300 administrations of the practice integration profile in primary care practices is the variation in what apparently is crafted and done in primary care practices is very substantial. And part of what we're going to be looking at as one of the secondary questions of our research is what happens to practice-identified PIP scores over a time series and translating that time series into the periods of time when the various phases of the implementation of integration occurred. For those of you who haven't seen it, the PIP has 6 primary dimensions that evolved from the lexicon of collaborative care that CJ and the Integration Academy generated: workflow, clinical services, workspace, shared care, case identification, and patient engagement. It's a 10-plus minute electronic measure, self-scoring, and in addition to scores on each of the dimensions, it generates a full score, full measure score. Anybody who responds winds up getting this kind of feedback, and it compares a site score with the median score of all other primary care practices who have responded. What we can see is that, as we had hoped, that primary care practices with behavioral health clinicians as part of them score at a higher level than primary care practices with no behavioral health clinician, as well as compared to, for example, other community agencies. And the differences are pretty consistent, not only in the total score, but across the dimensional scores also. Here's just a brief example of what one looks at as if one is using the PIP. It's just an example of a domain shared care, and how the elements are broken out, how it winds up scored, and it automatically self-scored. So we're coming back to our aims, and particularly now because what if we do all of this, what are the outcomes we're measured? Well, we're measuring health-related quality of life, quality of care, stability, and other patient-reported outcomes, and specific disease function. We're using overall degree of practice integration in specific domains, and we're looking at an explanatory model to be able to comment on the contextual issues that are part of any study's evolution. And I meant to say any practice's evolution. So we are going to include a sample of patients unknown to the practice that have specific inclusion criteria to sample and to test. That subset will be drawn from a larger sample of patients that we will provide the practices, essentially saying from this target that we are giving you, we're going to select n number of patients for follow-up to try to see if, in fact, you have identified similar sets of patients. So plus 18, at least a target chronic condition as listed, some evidence of behavioral problem. It could be diagnosis, it could be medication, it could be a number of different things. We're going to be particularly sensitive to gender and racial and ethnicity distinctions, if any, and no other exclusion. And there you see our anticipation of what the population is going to be that makes up our project sample. So evidence of multiple comorbid medical and behavioral problems. Diagnoses, medications, persistent failure to attain physiologic control of a medical problem, such as BP or A1C, unscheduled care in the clinic, hospital, or emergency room, 3 or more target chronic conditions. Here are the measures that we are going to be collecting from the sample patients, many drawn from the PROMIS measures generated at NIH, but also a range of different validated measures, as well as physiologic parameters. So what do we hope to be doing here? Well, I think it's important that we understand whether there are certain levels or activities as part of integration that are a floor for certain levels of effectiveness, and whether adding to that floor, in fact, impacts on greater effect sizes and outcomes. So we want to be able to look at that. Can you go into an incredibly busy primary care practice and say, here's a structured integrated intervention across a broad range of practices, different by ownership, different by location, different by size, et cetera, et cetera. What do the programs look like that appear to be able to do this to greater degrees and lesser degrees? And this whole issue, as many of you who know me, I'm very interested in whether different levels of integration as measured by the PIP at the moment affect levels of effectiveness and outcomes. So I wanted to do about 40 minutes, and I think that I'm darn close to that, and hopefully use the rest of the time to just open up for questions and open up the microphones and let's have a discussion. So I want to be clear about one other thing. This is our best guess, you know. I realize that we all have our own ways of looking at things, and I have my particular biases. I will say that when PCORI reviewed our application, they shared the following with us. It was quite a battle to get support for this. That what swayed the group was what they called the dream team of investigators and people involved in the project. They thought that we had done one of the best jobs with patient engagement they loved the research question, and that they thought that our intervention was novel and had great promise. Whether it is, we're going to know as soon as we can. We're at the beginnings, essentially, of a 5-year project, and we hope to have initial data someplace around 2 years. So with that, what do you guys think? Let's have some questions and discussion.
And again, if you're interested in commenting, just click the small green hand next to your name in the attendee button, and I'll unmute you, and you can ask that question or make that comment verbally. Also, if you're more comfortable typing the question in, we're happy to field those as well. Steve Malik, I see your hand is raised. I've unmuted you.
Thank you, Polly. Thank you, Dr. Kessler. I'm an actuary with Milliman and have been involved in behavioral health care for 20 years or so. And one of the key aspects of integration that I run into all the time is the CFO is wanting to know, okay, you're asking me to spend more money in behavioral health care, and I get that. Where's my return on investment? Where are the changes to the fee-for-service financial model? So how are you approaching the financial aspects of cost savings, cost avoided, return on investment, payer data? How is that fitting into all of your research here?
So that's just a wonderful question, and thank you for raising it. Those are all questions very close to my heart. The story goes that in the PCORI enabling legislation, our friends in certain parts of the healthcare industry had a very hard time with the idea of comparative effectiveness, including cost. Therefore, in the PCORI enabling legislation, they precluded cost comparisons as part of the comparative effectiveness work. So by their structure, we're very limited within the trial of what we can do. We can talk about resources used. We will be able to calculate utilization. And in addition, we are discussing impact on some very key and expensive medical conditions, not mental health and substance abuse, which are not very costly by comparison, but things like diabetes, hypertension, cardiac disease, asthma, things like that. So, well, we're limited in what we can do within the trial. We're going to do as much of it as we can, and I will say perhaps you'd be interested in having a conversation offline so I could discuss other work that we're engaged in and planning related to the questions that you're asking.
Great, thank you.
Okay, Dr. Kessler, our next question is from Jody Palaha. How will you handle the variability in clinician skill or even clinical decision-making in terms of what I think are more evidence-informed approaches rather than protocolized evidence-based approaches?
Thanks, Jody. That's also a very good question. And it is one that generated a ton of conversation within the team that was putting our project together. There was some consideration by some of our co-Is that we should limit practices to clinicians that were recruited
Dr. Kessler, we seem to have lost your mic. And we're not hearing you.
After this planning process, so that they can be clear about the type of behavioral care that was going to be provided. There was a concern that if you select from a co-located model, then often the way that that individual is trained and practicing may in fact be inconsistent with the model that we're trying to implement. Really? Okay. How about now? How about now? How about now?
I can hear you
now.
Dr. Kessler, I can hear you now.
How about now?
Yes.
Okay, I think can you hear me now?
Yes.
Okay, so now I'm back through my notebook. I do not know what happened. Jody's question. So the best we can do, since this is on-the-ground stuff, we know going in that we're going to have practice variation. In implementation, we're going to have different skill sets in clinicians. We know all that. The best that we are trying to do is mediate that by doing two things. By providing a high enough level of training to everybody in the practice, but certainly behavioral health clinicians, such that implementation of the training has a reasonable probability in interaction with the implementation plan of making changes. And, you know, for years I've been saying that our friends out at University of Washington who have done the impact work, one of the things that they have done incredibly in primary care was organize the chaos of behavioral services in primary care. And my hypothesis is organizing systems, developing implementation strategies goes a long way in addition to the work that winds up being done in the clinical office. So it's an imperfect model. We're going to look at the kinds of variation in training and background as secondary analyses, and it's the best model that we're able to come up with.
Okay, next question is from Lori Rainey. She asks, in addition to the PIP, are you going to measure actual outcomes like change in PHQ-9 or GAD scores to correlate integration and behavioral health clinical outcomes?
So again, firstly, this is not a behavioral health trial. It's the integration of behavioral care into primary care to treat complex patients. Whether or not things like the GAD-7 and PHQ are sensitive enough for that population remains to be seen. PCORI had a high degree of investment in the PROMIS measures. So left to my own devices, I certainly would be using PHQ and GAD, for example, because one should. But we are using the correlates of those measures that are embedded within the measures that PCORI wanted to use. So we will be collecting changes on anxiety, depression, substance use measures, but they will not be the GAD and PHQ.
Okay. The next question is from Roberta Renfro, and she is curious to know why you chose to develop the PIP rather than just use other profiles like the VIP.
Oh boy. Frankly, that's not the primary focus of this. It would take a very long time to talk about it. Let me just say this. Without a validated measure with clear psychometric properties, we're left with questionnaires. Our perception, whatever, 4 or 5 years ago, when we started looking at CJ's lexicon, was that we not only wanted to have a common vocabulary with the lexicon provided, but we wanted to have a measure derived from the lexicon that was empirically valid and would lead to sound psychometrics and the ability to distinguish different types of and levels of integration, so we can then use that data to contrast it with other outcomes research. That's the short response. Thanks for that question.
Very good. It looks like, Dr. Kessler, those are all of the questions that have come in via the question box. Let me check one more time through our attendees, give anyone a last chance to offer up a question or a comment. And I think we're at a fairly good stopping point at this point. Do you have any last comments?
I want to appreciate everybody taking their time to listen to our work. We're a work in progress, clearly. We will have a project website up within the next while, and intend to use it quite regularly to communicate different key aspects of our work and findings. And I hope that you will continue to be interested in our work.
Excellent. Thank you, Dr. Kessler, for the presentation today. It was very informative, and I think folks will leave with lots of thoughts and questions. One more time as a reminder, the recording of this will be on the CFHA website in the next few days. Thanks to everyone for joining us. Have a great afternoon.